Hello, this is John Kanelopoulos from our center here in Athens, Greece, the Laser Vision Ambulatory Surgical Center. We're going to go see a few corneas today. Let's jump this case. We'll go directly on our young patient. This is a 22-year-old young gentleman that came in from Cyprus, had the Athens Protocol just 5 days ago. We checked him 2 days ago for reepithelialization. He had a residual epithelial defect. Today he's fully epithelialized. We can see his images here and here as well. You can see how the epithelium is a little bit gritty, but fully epithelialized, does not stain with fluorescein. And looking even at the week's time, the differences between his pre-op, this picture is from October 12th, and today one can really appreciate the drastic improvement in the keratoconus, especially if you look at the difference map. The difference map shows a steepening in this area superior to the cone of 5 diopters and a flattening of the cone of 7.4 diopters. So we have a total change in the cornea differential of 12.5 diopters. This is a remarkable change, and this is basically the beauty of the Athens Protocol cross-linking, something that you can never get with laser alone or with cross-linking alone, because we know laser we employed here corrected about 1.5 diopters. Cross-linking usually flattens the cornea about 1 diopter. So if we go and look at this cornea today, we can see from the epithelial maps that fine, it's not perfectly epithelialized yet. We expect these maps to turn green in the long term, but we can see that over the area of the cone, the epithelium now is no longer very thin blue. It is becoming greenish, and this will improve with time. There's hyper-reflectivity in the fresh epithelium that has covered the surface. And we can also see here in this little fine, I'm going to try and zoom this, in this little fine line, the cross-linking line that we have described first in our publication of 2009 that shows the depth. We can see it out here as well. This is the cross-linking line. We'll see it clear at the 1 month interval where the clarity of the cornea will improve overall, and the OCT will be able to dive into the cornea better. But this depth and this width, this is a 9mm image by the OptiViewer Visionix Avanti, gives us the security that we went deep enough and wide enough. And looking at the metrics in the cornea, we had an IHD of 107 now to 39, an ISV of 78 to 40, subpar normal, keratoconus stage 2, and now the software and the pentacam says, well, maybe keratoconus, but we can appreciate how this cornea has drastically improved. And the patient jumped from 1/10 or 20/200 uncorrected to a 20/30 uncorrected, a remarkable change in visual acuity, but more importantly, stabilization of the cone. Let's see the other eye. The other eye, we can see he's an avid eye rubber. The epithelium is still blue over the area of the cone. He probably sleeps face down, and in this particular patient, sometimes in one eye, sometimes in the other eye. So this tells us that the keratoconus in the other eye is active and probably will need to be treated unless he stops rubbing the eye. We'll jump to a gentleman that we've done 7 years ago. This is a cornea treated with the Athens Protocol 7 years ago. The patient is now 32. And we can see his pre-ops in 2016, May of 16, so we're October of 23, so we are 7.5 years later. A very central, significant cone, steepest in the high 50s. Today, we can see the drastic normalization. We still have significant regular astigmatism. And when we look at the difference maps, we can also appreciate the drastic flattening of the cornea, almost 15 diopters in the center, which is the synergy between the topography-guided therapeutic normalization along with the higher fluence cross-linking, which can cross-link the cornea better through the laser treatment. Now, this particular patient, we're comparing the 2020 images. So this is September 2020, so 3 years ago, to today's images, and we see no difference in the epithelial maps. And we use this as the most austere, the most precise metric of whether the cornea has changed, and not the pentacam maps, because, for instance, if the epithelium had thickened, the pentacam may show a steeper image and thus suggest possibly progression of the keratoconus, which is not true if you look at the real data, total cornea thickness and epithelial thickness. As far as the minimal cornea thickness, it has increased. It was 389 in 2020, it's 399 this year. So the total cornea has increased mainly because the epithelium has remodeled and has thickened. Thus, we have an extra sign of stability of the disease, and what presented this year's ESCRS and ASCRS, in particular at the area where the cone was, the epithelium is no longer blue. It is green and yellowish. This is the area, this is the corresponding area, thus stability. And he has significant regular astigmatism. He's uncorrected 2070, corrects to 2020 with 4 diopters of astigmatism. Can this gentleman undergo now 7.5 years later a PRK procedure to make him emmetropic, since he's anisometropic between the 2 eyes? Yes, because the minimum cornea thickness is 473 in the center, where the myopic astigmatic ablation will take place. And we can see the cross-linking lines here, even 7.5 years later, are very deep. They're almost 90% depth, giving us the security that this is a very deep in effect and wide. I see cross-linking line here and out here. And I remind you, this is 7 years later. So we can definitely go in, if he's intolerant to contact lenses, and with a PRK procedure and the security that we have long-term stability of keratoconus, be able to make him even emmetropic and correct the significant anisometropia that he has. This is the other eye, again evaluated through these 7.5 years, no change. Actually, we're seeing an improvement. Please note that the steepest here has become a little bit flatter, so he's probably rubbing his eyes. The cornea is flattened about half a diopter. And this is probably due to a change in his age. He's born in 94, so since 2016, he went from 22 years old to now almost 30. So the cornea by itself has become stiffer, so the image of the cornea looks a little bit flatter, and this is the difference. Or additionally, or in contrast, he has stopped rubbing his eyes. Cornea thickness 534 back then, 551 back today, documenting this remarkable change. And we'll go to the other extreme of keratoconus, since this is our keratoconus monologue today. This is a physician. He's 42 years old. We can see the really frightening thinning of the cornea and the scarring here. It's a very central cone. He's a gas permeable contact lens wearer. We can see that the keratometry is not extremely steep. He's at 56, but the cornea is extremely thin. He's almost 200 microns in the center. The only thing that saves the day here is that the cone is very central. We're seeing the thickness maps with the anterior segment OCT, the Optiview Avanti, and the thickness maps here are reading 253 as minimum cornea thickness. This patient, obviously, when he stops being able to wear these RGP lenses, which are fitting pretty well, riding on the upper eyelid and sitting on the lower eyelid, give him a functional vision of 20/30, but with great variability and problems with the typical sand and particles in the atmosphere of Athens. Remind you, the physician is a pathologist, a busy pathologist, 42 years old, so a very productive decade of his life. So we discussed again here the possible need in the future for a cornea transplant if he becomes contact lens intolerant, if he develops hydrops, or if his scar from the contact lens touching here. This is the other eye, similar fitting of the lens riding under the upper eyelid and touching on the lower eyelid. So if he develops one of the above. And since we're talking about cornea, we'll close with a completely different case. Let's guess what this is. This is macular, classical macular dystrophy. There's a patient who has this in both eyes. He's functioning with 2400 vision in the dark. And we know that when he goes to bright light, he cannot see anything. He's an extremely smart gentleman, productive, a businessman. Only God knows how he can function with these corneas in his day. And here, segment OCT pretty much describes the traditional teaching that we did in residency and in my fellowships in Cornell and Harvard. I had the opportunity to train with some of the best cornea people. We can see that the solution here is just a cornea transplant. We explained to this gentleman that the vision will recover significantly. Time will tell how much of this mucopolysaccharide deposit will enter within the graft. In the future, this is a 9mm view of his cornea. We will obviously replace the central 8mm graft. He's procrastinating. We can see here, looking at the Optus images of the retina. We know Optus uses laser to scan into the retina, so we could not see anything if we used light. We can see that the optic nerve is fine, macula is fine, and there's really no reason in the world for this 57-year-old gentleman of not enjoying a normal lifestyle besides his fear of a cornea transplant. So we had this discussion. We urged him, even if it's not with us, to proceed with a cornea transplant. And I thank you very much for your attention on this big marathon between early keratoconus treatment and what we see at week's time. Obviously, protect from sun, use steroids and autologous serum for 2 months. And a patient that had Athens Protocol 7.5 years ago, before and after, and the accuracy of the treatment, because we discussed here with this young gentleman that we look at the difference maps to underline the accuracy of the X500 exodermal laser and cyclo-rotation adjustment, because this is the left eye. We know that when the patient laid under the laser, the left eye cyclo-rotated towards the nose, so counterclockwise, but the laser was able to adjust the treatment, and we see this in practice here. The actual flattening of the cone is exactly where it should have been. A laser that would not cyclo-rotate and adjust would treat this in a different area, and we would have a mismatch with the actual effect of flattening and superior steepening. We went to see the cross-thinking line with this young gentleman. We've seen an advanced keratoconic patient who's really struggling through RGPs and a busy physician everyday lifestyle. And we closed with a macular dystrophy that's not just in cornea texts, but occasionally you can see in everyday practice. Again, for those new in cornea terminology, we know there's granular, there's lattice, there's a combination between lattice and granular called avellino, and the classic macular dystrophy, which is diffuse throughout the cornea, and these pockets of mucopolysaccharide deposits in the cornea. Thanks so much. This is John Kanellopoulos from our day in Athens, Greece. Thought I'd take a few minutes and share with you some of the exciting stuff that we did. And this is just in the first 2 hours of my day here. Today, October 19th, in beautiful sunny Athens. Thanks so much for your attention.